Welcome everyone to the webinar on stroke in young adults. I'm Cheryl Bushnell. I'm Professor of Neurology at Wake Forest Baptist and Director of the Comprehensive Stroke Center and co-PI on COMPASS. And I'm going to talk to you today about the topic of stroke in young adults and also focusing on the epidemiology and scope of this problem. And this is by way of introduction to this webinar where we're going to have other speakers discuss a variety of aspects of this issue, and I hope that it will be informative and helpful for all of you who are taking care of stroke patients who are young. And obviously we have our disclosures about the funding of COMPASS, which is through the Patient-Centered Outcomes Research Institute, as well as REDCap support. So the objective today is to talk about the incidence and mortality of stroke in young adults and to describe the causes of stroke, which is a wider differential list than your average aged stroke patient, and to describe the impact on recurrent stroke throughout the rest of the young person's life, as well as quality of life and access to services. And so this is a topic that's gotten some lay press relatively recently. This is from November of 2016 in the New York Times, and it talks about how stroke rates have been declining in older people over the last 20 years, but have actually increased in those under the age of 55. And you'll see that this is a really important issue, and it's not just one study that's shown this. It's been shown in multiple studies that people who are in their younger years that stroke rates are increasing, whereas it may be decreasing in those who are older. Stroke in the young accounts for 10 to 15% of all strokes, and the incidence rates are generally pretty consistent across a variety of studies. Population-based study of the Greater Cincinnati Northern Kentucky Stroke Study is representative of the overall U.S. population, which is why it's so useful to follow those patients. And they are also doing a lot of subgroups, such as just the ages of 20 to 54 years. And what they've shown is that in whites, it's the rate of 48 per 100,000, and in blacks, it's much higher at 128 per 100,000 in this age group. Also, the ischemic stroke makes up about 69% of the stroke types, and intracerebral hemorrhage is 17%, subarachnoid hemorrhage 10%, and unknown is 5%. So it's important to understand the case fatality in these patients as well. A different study called the FUTURE study focused on ages 18 to 50, and they found that the 30-day case fatality rate is 4.5%. And the one-year mortality for survivors was 1.2% for TIA, 2.4% for ischemic stroke, and 2.9% for intracerebral hemorrhage. They also had a long-term follow-up, and after 9 years, 32% had a reasonably good outcome with relative independence and a modified Rankin score of less than 2. So, multiple studies, and I'll show you several examples of this, but this is from the nationwide inpatient sample, which is stroke or hospital discharges from across the country. And the CDC authors showed that there is an increase in the prevalence of ischemic stroke hospitalizations in young folks aged 15 to 44. And they also looked at the very young pediatric population as well, from 5 to 14. But the bottom line is that not only are the stroke hospitalizations going up in these young people, but so is the coexisting traditional stroke risk factors shown in this slide, where you can see that the rates per 100,000 hospitalizations are highest in males 35 to 44 years, followed by females 35 to 44, and then the younger groups below that. And then what they are showing is that these rates really follow the increase in in traditional stroke risk factors as well. Another set of data analyses from the Greater Cincinnati, Northern Kentucky stroke study between 93 and 2005 showed that the proportion of all strokes under age 55 increased from 12.9% in 93-94 to 18.6% in 2005. And so this is a really significant increase. And you can see the p-value is 0.002. So this is a major problem that we're seeing not only more strokes, but also more patients with these traditional stroke risk factors. From Helsinki, so it's not just in the US, Helsinki, Finland has a active research in following young patients with stroke. It's called the Helsinki Young Stroke Registry. And what they found is that the frequency of ischemic stroke rises sharply at age 40, and that the etiology of stroke and the risk factors start resembling those seen in the elderly and early midlife. But there's still a lot of different causes of stroke in the younger age groups. They also found that subclinical infarct, so you just do an MRI and you see small strokes on the MRI that were not causing clinical stroke symptoms. Those are subclinical infarcts. They were surprisingly common in the young. And this is also a study from the Helsinki Young Stroke looking at mortality by cause of stroke. And you can see large artery atherosclerosis is the top line, and this is causing the most significant risk of mortality, followed by cardioembolism, and then much lower on the list is the other determined etiology and undetermined etiology and small vessel disease. So those are much less likely to cause mortality than large artery and cardioembolism are. Unfortunately, because a lot of emergency room physicians and nurses may not be thinking about stroke in young people, it can lead to a misdiagnosis and a missed opportunity to treat with thrombolytics. And in this study of 57 patients aged 16 to 50, there were 8 patients who were misdiagnosed. That represents 14% of this group. There were 4 men and 4 women. Mean age was 38 years. All 8 were seen at non-primary stroke centers. 7 were initially discharged from the ED. And the predictors of being missing this diagnosis was an age less than 35 and posterior circulation stroke. And they found that obviously early use of MRI improves the diagnostic accuracy. And so they called for an increasing need for young stroke awareness, and that obviously this study highlights a lost opportunity for TPA and probably other now thrombectomy for treatment of acute stroke. The causes of stroke in young adults is, can be categorized by the TOAST criteria, and that includes large vessel atherosclerosis in 2 to 11%, small vessel disease in 7 to 14%, cardiac embolism 20 to 47%, other determined etiology 20 to 30%. And of course, this 20 to 34% here includes hypercoagulable states and other vasculopathies that are outside of the other categories. And then multiple etiologies is 2 to 3%. Some of the clinical clues for identifying the more common causes of stroke in young include a headache, and the location of the headache and the quality of the headache can be helpful. So if the headache is above the eye, it could indicate a carotid artery dissection. If the headache is posterior in occipital region, that could indicate a vertebral artery dissection. If it's the worst ever headache and comes on like a thunderclap within seconds, that can lead to the diagnosis of reversible cerebral vasoconstriction syndrome, or RCVS. And then a chronic headache could be indicative of an early onset genetic cause of stroke called CADASIL, or CNS vasculitis, or moyamoya, which is obviously they're rare, but they are almost always found in young people. There can be stereotyped transient ischemic attacks, and this can be from a fixed arterial stenosis that can occur in the setting of moyamoya or premature atherosclerosis or focal arteritis. And then the clinical setting can be important. So some patients with infections such as tuberculosis, HIV, or zoster can have strokes associated with that. Exposure to illicit drugs, vasoconstrictive drugs, pregnancy and chemotherapy, as well as radiation-associated carotid stenosis. And this can be important for people who have had childhood cancer and have had whole brain radiation or radiation to the neck. And this can lead to premature atherosclerosis. So very important to understand their early history. The clinical clues can also relate to the examination. So you can look at the arterial pulses in the temporal artery, which could point towards temporal arteritis, which it may be more of an older person's disease, but still important. The radial arterial pulse is abnormal in Takayasu's, or a large vessel arteritis. And then skin lesions could be indicative of syphilis or neurofibroma, or also not listed here is livedo reticularis, which you may see in antiphospholipid syndrome. And then rheumatological or autoimmune conditions such as lupus or Wegener's disease. And then you have connective tissue abnormalities that you might see with Marfan's or Ehlers-Danlos syndrome. And that's hyperextensible joints that you might see at the fingers, and then typical kind of tall stature and very thin stature that you might see with Marfan. The neurological examination should include looking for multifocal brain and spine deficits and peripheral nerve involvement, as well as some of the abnormalities you might see with bacterial endocarditis, for example, under the nails and in the eye exam. And then premature atherosclerosis, moyamoya. And you may see other abnormalities related to the eye examination as well. Laboratory and imaging clues. Obviously, most of these patients should get a toxicology screen, so that would include any abnormal substances. And usually we do a urine drug screen to identify illicit drugs. And then rheumatological tests are very important. Screening for lupus and screening for antiphospholipid antibody is very important in this population. And then you may see abnormal spinal fluid results as well, especially in the settings of infection and autoimmune disease. Brain imaging patterns can be helpful. Here is an example of string of pearls with middle cerebral artery stenosis in this MRI pictured here. You may see disseminated infarcts in vasculitis. It would be bilateral. And then you can see watershed infarcts with posterior reversible encephalopathy syndrome, or with reversible cerebral vasoconstriction syndrome. And then you may see other subcortical distribution infarcts with genetic syndrome like CADASIL. So there are a lot of different tests that we can do, and this is just one example of the list of tests for stroke in the young. You could also look for paroxysmal atrial fibrillation, and you can do longer Holter monitoring, looking for hypercoagulable states. I could do an entire seminar on hypercoagulable states if people are interested, because this is a very interesting topic and really too broad to include in much detail during this young stroke introduction. There's aortic arch atheroma. And the bottom line is that you can't really do all of them because your yield would be low, so you really need to tailor your workups to the right patient population. There are limitations to some of these tests. There's no significant large randomized controlled trial that can help tailor which test to choose, and that's unfortunately something that you can do a little bit more with older patients. And when you're looking for carotid stenosis, you can tailor this a little bit better. But here is a study from JAMA Neurology in 2013 showing the yield of diagnostic tests, and you can see that hypercoagulable studies were quite useful, toxicology and vascular labs. CSF exam, not so much. Cardiac echo, Holter, CT or MRI, and angiography in particular are better when you compare it to the older control group for the yield. Approach to treatment. Obviously, almost everyone should be on antiplatelets if you're not sure about the cause of the stroke. There is a potential increased risk for bleeding with vasculitis or with moyamoya, so you may want to have an angiogram to help with the ultimate diagnosis before deciding on the type of antithrombotic therapy. Anticoagulants are often used in dissection, although if you find a dissection and you don't see a stroke, you may still be able to get by with dual antiplatelet therapy. Steroids or immunosuppressive agents obviously are used if you do settle on a diagnosis of arteritis or an inflammatory condition. Statins are absolutely indicated in premature atherosclerosis, but maybe not so much in somebody with just a PFO and a pure cardioembolic type of stroke. There's some debate about what to do with blood pressure in the early setting, and we obviously allow permissive hypertension. This is in the guidelines for the first 48 hours. After that, I think it just depends on what you find, whether there is say, a middle cerebral artery stenosis. You may need to adjust the blood pressure depending on how they respond to lowering blood pressure. So we call that blood pressure dependent symptoms. And so you have to watch for that while they're still in the acute stroke setting. And then obviously treatment of infection and malignancy if that is found. And then there are surgical options, including intraarterial stents, usually of the larger vessels. Balloon angioplasty, EDAS, is a surgery that is done to treat moyamoya. So there are some surgical options, and we are often consulting with our endovascular colleagues on these patients just to make sure that we get the right treatment at the right time. Now, one of the issues I talked about earlier was young stroke patients missing the opportunity for thrombolysis, and the group in Helsinki did a study of their 48 young stroke patients who received TPA, and then they age matched their control subjects who did not receive TPA. And you can see a major difference here. So this is 27% versus 10% had a modified Rankin score of 0, 40% with TPA versus 22%, and then 81% versus 65% with a modified Rankin score of 0 to 2. So clearly, young people respond, and in many cases better than the older group, which is in the light gray bar, to TPA and have a better outcome. So really important to make sure that these patients are not missing an opportunity to get thrombolysis. Now, what happens after these patients have a stroke? The Italian Project on Stroke in Young Adults study was over 1,800 patients who were followed for 10 years who had a stroke between the ages of 18 and 45. And this is ischemic stroke only. And they looked through a long list of characteristics on these patients and found out which were associated with the risk of recurrent thromboembolic events. They used a combined outcome of ischemic stroke, TIA, MI, or other arterial events. And over the course of 10 years, the risk of recurrence was 14.7%. So the type of factors that really predicted the onset of this recurrence was a history of migraine with aura, a family history of stroke, circulating antiphospholipid antibodies, and medication discontinuation, which was either antiplatelet or antihypertensive agent. So this was by far the most significant. The medication discontinuation increased the risk of recurrent events by over 300% or threefold. And this is huge. So our efforts encompass to keep people on medications and figure out how to get them access, emphasize the importance of these medications. Look what kind of impact you could have on your patients by just educating them about the importance of continuing these medications. The other factors you may or may not be able to do much about. Family history, you can't. History of migraine with aura, we don't know if treating migraines actually decreases the risk of stroke, but theoretically, we certainly want to make sure that they're aware of their risk and that they continue their medications if they have a history of migraine with aura. And then, as I mentioned earlier, hypercoagulable states are important, but antiphospholipid antibodies is probably the #1 test to obtain in patients who are having strokes at young ages just because of this factor here, a 2.4-fold risk of recurrent events. And again, if we have interest, we could certainly do another webinar that's really focused on just the hypercoagulable state. And the other thing to just summarize here is the outcome after stroke in the young. And 7% can die, 14% may die over a follow-up of 6 years, 9% might have recurrent strokes, 0.4% with MI. The important thing is that the outcomes are not always great. Only 49% remain completely symptom-free, only 42% were able to resume work, and a majority of survivors reported emotional, social, or physical residual symptoms that lessened their quality of life. So this is really, really important. And this is shown in a study from Denmark where they followed patients and showed that young stroke patients had a 2 to 3 times higher risk of unemployment after 8 years of follow-up. And, this is the Dutch population. Return to work programs should be developed, adjusted, and evaluated in order to diminish the negative effects that unemployment can have on patients' life satisfaction and to limit the socioeconomic consequences. So obviously we can't find work for our patients, but we do need to be aware of how this impacts their life going forward after a stroke. And that particular study from the Dutch population was commented on by Anish Singhal, and I wanted to acknowledge Dr. Singhal for him allowing me to use many of his slides. He and I do a course together on stroke in young adults at the American Academy of Neurology, so many of these slides are based on that, and he was instrumental in helping me prepare this, and also he is one of the world's experts on some of the causes of stroke in young adults. Now, the last thing I want to talk about is access to services, and this is data by one of our colleagues, Dr. Purvi Betker at Duke, and what she showed is, looking at claims data, is that there are a lot of patients who don't receive services, and what's important is patients younger than 65% of them did not receive post-acute services after discharge from a stroke diagnosis. So here you have those who went home without services, and then you have the green line showing inpatient rehab, the yellow showing home health, and the red skilled nursing facility. So this is really important that we understand the need for services in these patients, the impact that stroke can have on their outcome and their well-being, and that's what COMPASS is all about. We're really trying to make sure that patients receive services whenever possible after a stroke. So the take-home message is that stroke in young adults is increasing in frequency. There's also data showing that stroke in pregnancy is increasing. The causes of stroke in the young are more diverse, and so we often do need to do more diagnostic testing and consider a wider differential. The risk of recurrence can be quantified based on migraine with aura, family history of stroke, circulating antiphospholipid antibodies, and medication discontinuation, and that stroke really does impact these patients in a significant way throughout the rest of their lifespan, impacting their employment, their disability, their quality of life, and development of other comorbidities. So I would like to stop there, and I hope that you found this useful, and I'm sure you'll enjoy the other two speakers for this webinar. Thanks so much.
Hello, I'm Denise Sorensen. I am the Stroke Program Coordinator at Piedmont Medical Center and a former stroke coordinator that worked with the COMPASS study. Today I'm going to be talking about young stroke and post-acute nursing care considerations. I wanted to talk with this slide because we have some pretty amazing results with our young stroke patients, and they have some pretty awesome outcomes. But where we feel like we're celebrating a success, their work is just starting. Today we're going to briefly review the prevalence and etiology of young stroke, identify nursing education and post-stroke assessment opportunities for young stroke survivors, discuss some concerns that have been expressed by young stroke survivors, and describe one model for creating and sustaining a young stroke support group. Between 2000 and 2010, hospitalizations for ischemic stroke decreased nearly 20%, but among people 25 to 44, there was a 44% increase in the rate. Some of the reasons might include improved identification of young stroke cases and increasing use of the brain MRI, but unfortunately we're seeing increased vascular risk factors in young adults: diabetes, hyperlipidemia, obesity, smoking, and rise in the use of illicit drugs. In my state, South Carolina, the prevalence of hypertension is almost 32%, high cholesterol 38%, 20% of adults smoke, 66% of adults are overweight or obese, and this statistic surprised me. There are about 350,000 adults in South Carolina who've been diagnosed with diabetes, but there's another 100,000 that are not aware that they have the disease. Cryptogenic strokes account for at least half of overall stroke in patients less than 30 years old. Cervical dissection is the second most common cause, up to 25%. Other causes can include hypercoagulable states, migraine-induced strokes, genetic disorders, inflammatory and infectious processes, illicit drug use, and maybe TFO. I think the jury's still out on that. But it's really difficult for young stroke survivors not to understand why it happened to them. They have a lot of concerns that young people generally do, but they're expanded by or impacted by the stroke, family and relationships, an increased sense of fatigue and sensory overload, isolation and self-image changes, physical and cognitive rehabilitation challenges, and career and finances. When you're talking to your young strokes, let's start on this slide again.
Sure thing, no problem. You can start from the top.
Okay. When you're counseling your inpatient post-stroke survivors that are young stroke patients, remember to remind them EC does it. Post-stroke fatigue is normal, and patients need to ease back into the routine. Their brain needs time to heal. They're processing information differently, and it takes more energy for them, and that makes them more mentally exhausted. They can also have changes in sleep patterns as a result of their stroke, and so if you can, advise them a regular meal and sleep schedule. Emotions will come to the surface much more easily when they're tired. Young stroke patients may feel especially anxious after stroke, and causes of anxiety can be expanded when they don't understand why the stroke happened or how to prevent it from happening again. If they've been affected by aphasia, they have difficulty communicating. They may be unable to drive or immediately return to work. They're concerned about taking medication and potential side effects. They can feel embarrassed or uncomfortable in social situations. As everyone does, they have difficulty understanding how to navigate the healthcare system. They can have financial concerns and dealing with disability, and they want to make continued progress toward recovery on an ongoing basis. They also may be impacted by sensory overload. After a stroke, your brain just isn't able to process and filter multiple inputs. Background noises can be especially difficult if it's something like a vacuum cleaner or a leaf blower that's a background droning noise. That can be especially difficult for them. Social situations where there are multiple people talking, being in crowds, family gatherings can be challenging, as we all know, but it all equals up into too much information for them. And they need to be encouraged to be sensitive to their feelings and take themselves away when they're overwhelmed in situations. Some post-discharge assessments considerations that you may want to think about when you see them in the clinic, or depression. Does the patient need medication or a psych referral? Do they have a previously unrecognized cognitive impairment? Do they need a speech referral or neuropsychology testing? And is there excessive caregiver strain evident at the clinic visit? Do they need additional home support? Have they gotten the appropriate respite care resources? Do they possibly need short-term placement? Did they go home too soon? And are they in a safe environment? I want to shift gears a little bit and talk about our experience in Charlotte establishing a young stroke support group and how we went about the process. I can tell you honestly, it was a little bit daunting at first, and we went into it with some trepidation. But this was just kind of our model about how we established our group. We identified the participants in the group, which were young stroke survivors, caregivers, and we did include aneurysmal stroke. We established a meeting time, frequency, location. We wanted to focus on accessibility and parking for the patients, so it was easy for them to navigate. We set up a monthly meeting schedule in the evening, and we utilized the neurology office waiting area as a place where we all met. We looked at marketing opportunities to attract stroke survivors and their families outside of our hospital network. We did use our hospital website. We used the American Heart Association, American Stroke Association website, the Brain Aneurysm Foundation website, and there was also a local support group website in Charlotte that we utilized. We included support group information with our inpatient education and again at the Bridge Clinic visit. And we encouraged the neurology and neurosurgery offices to share our meeting flyer with their patients. We kept our meeting at about 1.5 hours. We had an expert speaker for the first 15 or 20 minutes. It was an informal presentation with questions and answers afterward, and the remainder of the meeting for general discussion. We planned topics and potential speakers as far in advance as possible, and we tried to involve the group in the topic selection for future meetings. We published our support group meeting dates and times on a yearly basis, set up an email contact group with the participants' permission, and sent it out in a blinded email for reminders 2 weeks and again 1 week before the meeting. This is just a list of the meeting topics and speakers that we used for our support group, and I'm not certainly going to go through all this, but we included any healthcare provider that could talk to young survivors about issues that impacted them. Didn't have to be a physician, but we encouraged physicians to help participate, and they did support the group. Some lessons learned from our experience. Facilitating a stroke group is humbling. I learned more from the survivors than I did in the inpatient hospital setting. Developed a huge respect for their challenges and their resilience and how they dealt with their situation. You need to expect to be flexible. You can have changes in speakers at the last minute. You kind of need to have a backup in your back pocket. You also never quite know the direction that the group is going to take. The time and place information needs to be clearly communicated and reiterated, especially immediately after a stroke. People were pretty overwhelmed and they had some confusion about when and where the meeting was going to be. It was interesting because the young stroke survivors feel very isolated. A lot of them told us that they'd never been in the room with another stroke patient before, another stroke survivor, and they learned a huge amount from each other and gained a great deal of support from one another. We did have some members that, as part of their recovery, did a lot of research on a stroke and stroke etiologies and their own recovery. And some of them knew a lot more about some of the stroke-related topics than we did. The group tends to warm up over time, and so we had to be kind of specific about setting time parameters to end the meeting. Sometimes we found that people would come and they were hesitant to talk. In the last 5 minutes, when they knew we were wrapping up, all these issues kind of came tumbling out. And there were evenings that we just left them talking amongst themselves in the lobby after the meeting. Again, identify common themes that you hear among the survivors for future meeting topics. The best part was hugs from patients and families feel really good, and know that it's going to be an emotional experience, so you want to have plenty of tissues available. So I want to thank the Compass team and all the participating sites because you're making an amazing difference for all stroke patients. Thank you for the opportunity to talk to you today. And if you have any questions, you've got my email contact. Please feel free to reach out.
Good afternoon, everyone. This is Amy Edmonds, and I'm delighted to be joining you today. I'd like to start with an expression of gratitude for all of you in this audience who provide such tremendous care to the members of my young stroke community and their caregivers on a daily basis. Today, I'm going to be sharing with you the many ways that young stroke is changing the way that we view stroke care. I'll be sharing 3 objectives with you today: self-introduction, a young stroke survivorship discussion, and then I'm going to close with recommendations to help us move forward. So this woman had a stroke at 43. I was running 5K races. I've always had a healthy diet. I had never been a smoker, was not abusing substances, and still I had a stroke. And so as you might well imagine, I was very curious as to why this happened. On the day that the stroke presented, I had temporary blindness and I had confused speech. My speech wasn't slurred. I was actually repeating myself over and over like a parrot. And so by the time EMS actually arrived to my home, the symptoms had actually gone away. And so they actually refused transport of me to the hospital because I looked so well. So that was in 2002. And immediately following my stroke, I did not require any rehabilitation. My deficit seemed to be memory loss. And so my stroke occurred in January of 2002, and the following December, I had enrolled in graduate school at Murray State University with a research focus of stroke in young adults. And as a result of my thesis, I proposed that America needed to have an advocacy organization to voice the unmet needs of young stroke survivors. And so in 2005, I launched that organization, and I called it Young Stroke Incorporated. And then we have provided, as an organization, education and awareness raising of the increasing prevalence of stroke in young adults. And then it was our pleasure to host the first international scientific conference on stroke in young adults in 2015, and that was held in Jacksonville, Florida, in conjunction with Mayo Clinic. We also hosted a second event in the year 2016. Following my presentation experience, I was invited to present at the World Stroke Congress first in 2012, and I have made presentations as well at the International Stroke Conference, always addressing the issue of stroke in young adults. And so in 2014, I was elected by my international peers to serve the board of directors of the World Stroke Organization, and I was very flattered to be the first American survivor to serve in this capacity. I have also received funding from the National Institute of Neurological Disorders and Stroke, and they supported our Young Stroke 2016 conference, which was also held in Jacksonville. I have also been awarded through the National Institute on Minority Health and Health Disparities, and most recently, I launched the Young Stroke Media, and we are currently publishing an online newsletter that helps to ignite global discourse about stroke in young adults. So let's get started with our discussion on young stroke. So for the purpose of my organization, we define stroke in young adults as being a first-time stroke event for those 18 up to 65. And we use this broad category based on the way that the American healthcare system works. If you're under 65, everyone is pretty much in the same boat. So I do not make a distinction between a cutoff at 40 or 55 because really Medicare becomes a key determinant. It is interesting that when we look for a definition of young stroke, there is no global standardization. And this is a huge impediment to research because we are unable to make an effective comparative analysis across studies. Bo Nording, who was the keynote speaker at the very first Young Stroke Conference in 2016, did an excellent job, I thought, of making this visual description of young stroke. He was making a comparison of young stroke to geriatric stroke, and basically he was saying that for geriatric patients, stroke occurs at the end of life. And so you're looking at end-of-life disability that will perhaps last 10, 12, 15 years. In comparison, when a stroke occurs that we define as a young stroke, now we're talking about a patient who's going to have a lifelong disability. According to the American Heart Association, 1 out of every 5 strokes today in America is a young stroke, occurring in someone under the age of 55, which is their parameter. We do know that stroke among young adults is an emerging population, and that's especially true here in the stroke belt region, and especially so in the stroke buccal region, which is where I am in South Carolina. Currently, the state of South Carolina, for example, we know that stroke within this age group now exceeds 50%. Foundation of young stroke is not merely lifestyle. It's not just about hypertension, diabetes, and obesity. And with also very important to recognize is that causation for many young stroke patients is not likely preventable. And that's because we are experiencing blood disorders, aneurysms, genetic factors. A high percentage of our strokes are identified as cryptogenic, and that is actually the category that my own stroke falls into. And for young adults, more than 30% of our strokes are grouped in this category. And that simply suggests that there is a tremendous opportunity for more research to better understand our experience. We also are experiencing more than our fair share of hemorrhagic strokes. We have strokes as a consequence of pregnancy, and there are also a large number of young adults who experience dissection. Some of the challenges of our survivorship experience that are unique to young adults are that when stroke happens, it impacts all of the major milestones of our lives, such as when we're raising a family. Many young adults are still rearing children at home when the stroke happens. Many of them are trying to pursue higher education. They're in the midst of building careers. And financial planning, well, for many of them, they're just getting started if they had an opportunity to make any significant accrual at all. And so in this regard, these are all ways that young adults distinguish themselves from more geriatric patients, or who tend not to have such issues in their lives at their time of stroke. And so it's also worth noting how young adults perceive themselves. Many have held a position in society they desire to recapture. I think that really summarizes where many of us find ourselves today. For example, I'd like to show you a friend of mine in Hilton Head. Robert McPherson had a stroke at 51 years old. And what I think is so cool about Rob is that, yes, he did write a book, and yes, many stroke survivors write books of their stroke experience. But what makes Rob really special is that he was actually in the midst of writing a memoir about having driven cross country on his motorcycle at the time of his stroke. And so it was extremely significant for him as a milestone of his recovery to complete his memoir. And so he's very distinguished as a post-stroke author for having published a book that doesn't even touch his stroke experience. He is totally focused on that bike ride, and it was my pleasure to attend his very first book signing, and of course he came in full garb of his Harley Davidson, and it was just a tremendous evening and a tremendous celebration of his recovery. Another example, I think, the confidence that many young survivors bring through their recovery is demonstrated by young women who choose to become pregnant post-stroke. And it was my pleasure to have interviewed Dr. Cheryl Bushnell for an article I wrote for Stroke Connection magazine in the spring of 2016. And I'd like to introduce you to two of the survivors that we addressed during that feature. The first was a young lady from Christy Harding from Salt Lake City, Utah, and the cause of her stroke was a patent formin ovale, a PFO. And so post-stroke, she had experienced no deficits, At the time that she decided to become pregnant, she had been using an IUD, and she was able to deliver 2 healthy, very energetic little boys, and one was born in 2013 and the other 2015, and it was my pleasure to have actually met Christy when I was passing through Utah a year ago. The second young lady is Ashley James Collins, who is in La Place, Louisiana, and she had experienced a brain aneurysm. And what's interesting, too, about Ashley is that she currently still has some left side paralysis. She was using no contraceptives, and she has had 2 cesarean deliveries with her children. And so in closing, I'd like to leave you with some thoughts for consideration. We desperately need to have standardization of a young stroke definition, and we need the research community to come together on that so that we can all take a giant step forward. There is a tremendous opportunity to embrace global self-management models. Compass is doing great things here, and we need to also broaden our awareness to the fact that there are many self-management models that are starting to pop up. It's as if now that this concept has become, there's been raised awareness about this concept. You know, you throw things out into the universe, and so much good information is starting to come back to validate that we're all moving in the right direction. We need to maximize the reclassification of stroke from cardiovascular to neurological and really take advantage of the additional research funds that should be coming down the pike after the new ICD goes into place this fall. We need to encourage annual stroke assessments. We need to have annual stroke assessments in the way that we have assessments for cancer patients for 5 years to make sure that they're cancer-free. We need a similar assessment for our stroke patients. We need to promote respite care among all of our caregivers. And we need to message to our communities beyond FAST. We need to also make them aware that headache and that vision issues are also signs of stroke. I really appreciate your time today. I hope that I shared some information with you that may be of benefit, and I look forward to taking your questions. Thank you so much.